Afternoon. My name is Hannah Potts, and this video is intended for the education of any allied health employee, such as a patient care tech, nursing assistants, emergency medical techs, and imaging technicians or technologists, on the topic of sex and gender differences and the complexities of the two, the current management of gender-based medicine disparities, and ideas on how to approach the future of gender-based medicine. So I want to start by highlighting the differences between sex and gender. Sex refers to the biological differences between males and females, such as their genitalia and genetic differences. Gender is a little bit more difficult to define, as it does refer to one's self-perceptions or their concept of themselves, like their attitude, social characteristics, and expectations that they have about their role as a male or a female in society. Even the term male, female, man, woman, they're not necessarily interchangeable. What it actually means to be male or female originates from the physical characteristics derived from sex chromosomes, genes that create internal and external genitalia, and natural hormones that are not induced by medication. Being a man or a woman holds a little broader meaning, which includes the cultural concepts of masculinity and femininity. Because gender is not as easy to define, I do want to go a little deeper into what creates a person's gender identity. Gender refers to the socially constructed characteristics of women and men, such as norms, roles, relationships of and between groups of women and men. Gender roles vary from society to society and are not set in stone, so they can be changed, but gender roles in some societies are more rigid than others. In many societies, men are increasingly taking on roles traditionally seen as belonging to women, such as staying at home and taking care of their children, and women are actually playing the parts previously assigned to men, like going to work and being the breadwinner of the household. Back in 1930, 1940, this was kind of unheard of, but now in the 2000s, it's actually very common to have a male stay home and take care of the children, and a woman go to work and be the breadwinner of the house and be making all the money. So I want to touch on transgender. Sometimes a person's genetically assigned sex or what they were born with does not line up with their gender identity or who they feel they should be or should have been born as. These folks might refer to themselves as transgender, non-binary, or gender non-conforming. So, and I'll touch back on that later, but I want to shift to the topic of biological and behavioral differences between males and females that are crucial to providing adequate health care. Sex and gender are actually considered important risk factors for a patient. The biological and behavioral differences between the two can affect manifestations of symptoms, epidemiology, and pathophysiology of many widespread diseases. Incredibly, the typical gender differences in healthcare include differences in the use of preventative measures, the prescription of drugs, health insurance reimbursement, and even acceptance into particular surgical therapies such as pacemaker implantations or even a heart transplant. On one hand, a person's biological sex influences their health by modifying behavior. Testosterone, for instance, causes aggressive behavior that can be associated with risk-seeking and neglecting personal health. On the other hand, gender behavior can modify biological factors and thereby affect health. Exposure to stress, environmental toxins, poor nutrition, and lifestyle choices can induce genomic changes in adults and children. An example of these differences can actually be seen in heart disease. Women are at higher biological risk for having a heart attack than men are. There are traditional risk factors for both men and women, such as obesity, high blood pressure, and diabetes. But there are risk factors that relate specifically to women or those born genetically female, like increased hypertension and higher testosterone levels during menopause, and autoimmune diseases such as rheumatoid arthritis, which is more common in women than men. A 20-year follow-up study actually showed women who suffer from endometriosis are 62% more likely to have a heart attack. 176 million women in the world suffer from endometriosis, which is, I think, roughly 10%. 62% of that 10% of women in the world are at a huge increased risk of having a heart attack. But this leads to the discussion of sociological risk factors for heart disease, which happens to be higher in men. Comparisons between genders reveal differences in psychosocial and behavioral coronary risk factors, including excessive alcohol consumption and smoking, favoring women. Stress also plays a huge factor in heart disease, as stress raises blood pressure and overall It appears men's coping mechanisms with stressful events may be less adaptive behaviorally and emotionally, contributing to their increased risk for heart disease. So this is just one of the many examples of male and female biological differences versus sociological differences and how they can affect each person's health differently. So I'm going to move on to how transgender medicine is handled and what some of the characteristics and barriers are. To start, the term transgender is kind of an umbrella term that describes people whose gender identity differs from the biological sex they were assigned at birth. Some of those transgender people may desire medical assistance or even for surgical interventions to transition from one sex to another. They may identify as transsexual. Transgender people do suffer significant health disparities in multiple fashions. Stigma and discrimination within medicine and healthcare provision may, in general, impact a transgender person's desire and ability to access appropriate care. The biggest barrier to safe hormonal therapy for transgender patients is lack of access to medical care. Despite guidelines and data supporting current transgender medical treatment, transgender patients report that lack of providers with expertise in transgender medicine is the single largest component of lacking access. So transgender treatment is not taught in conventional medical curriculum, and very few physicians have the knowledge to treat these patients appropriately. The barriers can exist anywhere a transgender patient would actually seek medical treatment. For example, in an emergency room, a medical professional or the staff may be preoccupied with trying to use the patient's correct pronouns, such as he, she, him, her, and using their assumed name over their legal name, and it takes their focus away from doing their job, and it could possibly put the patient in danger if they miss something. Another issue I want to shed some light on is the lack of gender-based medical prevention and management and how this negatively impacts care for men and women. And for this, I'm going to go back to heart disease and the symptoms of a heart attack. The most typical symptom of a heart attack is crushing chest pain that radiates to the left arm. Women are less likely to experience severe chest pain and oftentimes just experience discomfort or pressure behind their sternum, and this can be induced by rest or sleep, which is opposite of male symptoms that are induced by exertion or emotional exertion, exhaustion. Women also feel pain in areas around the chest, including the jaw, neck, abdomen, legs, and arms, different than men who feel pain radiating into their left arm. Women generally exhibit symptoms that are not well known, leading them to delay seeking treatment for fear of being seen as overdramatic or attention seekers. There are many new initiatives for reformation of gender-based medical care being brought to the table. One of those approaches includes biomedical research that is not a sort of male-only approach. For instance, until about 1990, women were essentially excluded from clinical drug trials. And even today, in many areas of lab research that are relevant to medicine, we study in laboratory animals models of human disease. And in many of those arenas, the studies are done exclusively on male laboratory animals, and then the results are just assumed to be identical in females. So there's kind of an assumption across much of medical research for decades that studying things in males alone is good enough. Another point in medical training that is based on average patient being a male 170-pound white patient. And so we're not aware of some of the other possible challenges that providers are facing when they're treating other types of patients, which is pretty much everybody else. There's things like hip replacements. Those are designed for the male body. Surgical instruments. Those are designed for male hands. The field of medicine and medical research used to be male dominated. Now that females are stepping into the ring, they're creating waves and making changes that will accommodate a female and her needs. Women have higher rates of osteoporosis, autoimmune diseases, such as Alzheimer's, while men have higher rates of Parkinson's, chronic liver disease, and lung cancer. Even more significantly, a single disease can affect men and women differently, including everything I spoke about earlier, again, autoimmune, colon cancer, diabetes, and some mental health disorders. Through these gender and sex-related differences and manifestation of diseases have been long known, relatively little research has been carried out to understand why and determine whether men and women should receive different treatments, such as higher or lower doses of medication or different medications entirely. Now that these considerations are being taken by the medical and biomedical research communities, The initiatives and the resources to create an equal threshold of medical care for both males and females is bigger than it ever has been.